And welcome back. Adam Hardage is a beast. He's a warrior. He's a soldier, speaking many languages. He served this country. We respect that. But he just did not leave it on the battlefield. He decided to take it to the battlefield of telemedicine. And he is the CEO of the virtual exam room and much more. And he joins us for this edition of the Armstrong Show. What branch of the military did you serve in?
Hey, Armstrong, thanks a lot for having
Yes,
me.
my
Appreciate
pleasure.
it. I was a graduate of the Air Force Academy in 1997 and served in the Air Force until about 9/11. Then wanted to go to war, and so I crossed over to the Army and then spent some years with the Army and then ultimately the intelligence community.
Did you just see too much of veterans being neglected in terms of their health care and being taken care of? Or did you see too many bodies and casualties on the battlefield that you realized that there's just got to be an alternative to going to the hospital? There's just got something has to develop virtually. What led you to
Sure.
the VER?
Well, it's a funny story. In 2011, I was in Afghanistan and I woke up one day and I had basically gone blind overnight. Couldn't see, couldn't walk.
Really?
Yeah, it was very strange. So there was a series of misdiagnoses. They thought that I had maybe been blown up. They thought that I had a traumatic brain injury. I then got misdiagnosed with a brain tumor. Ultimately, I got shipped back to the U.S. and a specialist realized that I was an MS patient, multiple sclerosis. He took one look at me, didn't even touch me, anything else, and he said, "Boy, if we would have been able to see you from, anywhere in the world, I could have told you this if somebody would just put me on a video chat with you." And that was kind of, I didn't realize it at the time, and in 2011, that's kind of planted the seed for it. And then fast forward 5 years, and I met the inventor of this amazing new technology called the virtual exam room, and we hit it off, and we decided to go into business together.
Take us to the virtual exam room. Take us there for beginners and help us see it through your eyes exactly how this works.
Well, it's very straightforward. The big difference between telehealth and telemedicine, let's start with that, because telehealth is a big buzzword these days, right? Telehealth is just the ability to have a video chat or a phone call with your doctor. It's nothing more than that. Telemedicine is the ability to remotely diagnose, and that's what we do. So let's say granddad is having chest pains, and he is an hour and a half away from the hospital, and the ambulance comes to pick him up. Well, is he having a heart attack or is he having an anxiety attack? We don't know. Is it possible, Betty Sue is having a stroke or is she having some kind of palsy incident? We don't know. Well, with the virtual exam room, a remotely located ER physician can diagnose that like that.
Why is it so efficient and effective?
It's because it's cutting edge telecom technology that instead of this, what makes this different from everything else is instead of doctors saying, "Hey, let's put an app on an iPad and let's make it do video chat." We had telecom giants design an incredible compression algorithm and capability for video, audio, and data, being able to cannibalize one single pipe of bandwidth, if you will, into 3 different things to where we can transmit video, audio, and voice at very, very low bandwidth, which the military really loves. And then as well, simultaneously push those diagnostic readings across the screen. So a doctor sitting in, let's say, a Starbucks, sitting on a laptop, can speak to the medic in that ambulance who has hooked up granddad to a 12-lead EKG, and that ER doc sitting in Starbucks can say, "That man is having a heart attack. Do not take him to the ER. Go straight to the cath lab." And he can call the cath lab and say, "You guys have an incoming heart attack. You need to spool up right now." Same kind of thing with stroke. So it's incredibly powerful, especially for those who are in the underserved areas, rural communities, outlying. So it's game-changing technology.
Talk about the impact of what you've revolutionized has had on people's lives.
I think this technology in general, it's even just starting in the beginning. It's going to change so many things over so many years to come. And since the outbreak of the coronavirus in February, well, really it started in January, but we really started paying attention to it as a nation in February. It's changing everything. No, people are not going to go back to sit in the waiting room of the doctor's office. They're not going to go sit in the big waiting room, to go sit in the little waiting room, to go wait for the nurse to come in and take their temperature, to then go into another room to go have the doctor come see them for 2 minutes. Whereas now, you can sit down with this thing. We can do your complete vital signs, EKG, remote stethoscope, so a doctor can see and listen to a patient's heart, listen to a patient's lung sounds. We can do all of the diagnostic stuff that we would do in an in-person visit. We can look in your ears. We can remotely intubate you. We can do a spirometry test. That's a lung capacity test for maybe somebody with COPD. We can check your sugars for diabetes. We can do all these things remotely. So there's no need for most of the time to go into the doctor's office.
You said earlier in a conversation that this could impact COVID-19. I'm sure our national audience wants to understand what that means.
Absolutely. Well, so when we talk about COVID-19, the name of the game is isolation and containment, right? So that's why we're doing social distancing. That's why the mask wearing. That's why all these other things. Telemedicine is the answer to that. So you can still get the care that you need. So there's a lot of conditions out there that are not being treated right now because primary care docs are not getting visited by patients. Patients don't want to see, don't want to risk it, don't want to go into the hospital. So they're going to let that. That diabetes type 2 that they've had deteriorate. They're going to let their weight gain go up and hypertension become a bigger problem. So the name of the game, if it's isolation and containment, I get it, but let's arm these people with technology to actually still be able to get the care that they need, and that care is telemedicine. But there's a second aspect to this. The other thing you need is testing. Testing, right? So we are very, very proud to have been selected as the exclusive distributor for the U.S. Defense Department for the only FDA authorized at-home saliva-based COVID-19 test. So 98% accurate.
Explain the saliva. Details
Yes, sir.
here.
Would you rather have a nasal swab go up and touch your brain, or would you rather spit into a cup?
I've seen people in tears from the nasal
Yeah.
swab. Of course.
Or sneeze or cough as a result of that.
And so how does it work?
It's literally a container sample collection kit, which think of it like a test tube, really. It's going to come to you. You spit into it. It's 1 milliliter of saliva. There's a solution that goes into it, which makes the virus inert, safe to transport. That goes into a biocontainment bag, goes into a box, gets shipped to a lab processes it. And within 24 hours upon receipt at the lab, you know whether or not you have coronavirus to a 97.5%.
What about this product, making sure that it gets this virtual exam room, it gets to undeserved communities?
Yes, that is a very, very, very big push. And we have been trying to work very diligently with the Veterans Affairs organization and then as well HHS and some of the other entities. But truthfully, we're still at the educational process because there's a big confusion at whether it's at the highest levels of CMS, HHS, CDC, FEMA, any of the other federal agencies. Most of them don't even understand the difference between telehealth and telemedicine, whereas telemedicine is absolutely key. And I'll tell you too, one of the areas where we really, really shine and help is with what we call our Ever Home device. So that's a tablet that goes home with some Bluetooth peripherals where a patient in their home, and we use this for chronically ill Medicare patients all the time. When we say chronically ill, we're maybe talking about patients with 4 or 5 comorbidities. Type 2 diabetes, hypertension, obesity, depression, COPD. These are patients that need an ongoing care program. And so we'll do remote patient monitoring and chronic care management where we check in with them every single day. And you know what? We're located in Richmond, Virginia, but my patient is in Wyoming or Utah or California, or Arizona, So it's an amazing ability to reach out and touch those people, especially those who are in either underserved or underconnected communities.
Adam, I cannot thank you enough for your innovation genes, but willing to put it all on the line. And in closing, I want to give you an opportunity to talk about whatever you want to talk about that we've not addressed through my line of questioning to you today.
I will just say that from my perspective, if we look forward, leveraging technology that is here now today and understanding that the world is changing before our eyes. I would say adapt or die.
I'm Armstrong Williams. Don't go away. We'll be back with much more.